Thank you for the opportunity to present today. I would like to also thank my co-authors on this analysis. So postoperative visual loss is a rare but devastating complication following spine surgery. The reported incidence has been between 0.03% and 0.2% in literature, usually with individual case reports, series, and retrospective reviews. Suspected causes of visual loss include most commonly ischemic optic neuropathy, which can be subdivided in anterior and posterior divisions, as well as central retinal artery occlusion and cortical blindness. The objective of our analysis was to look into the SRS-MNM database to assess the incidence, perioperative patient characteristics, and likelihood of recovery from visual loss following deformity surgery. So we queried the database from 2009 to 2012 and analyzed demographic information. We looked at perioperative factors including positioning, time in the prone position, procedure type, operative blood loss, operative times, head support and position, and visual acuity specific outcomes as well. In terms of our results, so we found 21 patients out of 167,000 that developed this complication for a rate of about 0.013%. The actual rate decreased from 2010 to 2012 significantly. The rates for patients with primary diagnosis of kyphosis were significantly higher than those with diagnosis of scoliosis or spondylolisthesis. Some of the baseline characteristics can be seen here. The average age was pretty young, 35 years. Most patients were ASIA 1 or 2 in terms of their classification, and the most common comorbidity was hypertension at 23.8%. The scoliosis and kyphosis curve magnitudes can be seen in the graphs on the right. Surgical factors. So prone positioning was utilized in 95% of patients with an average time of 264 minutes. Fusions were performed in about 90%. Osteotomies performed in about a third of patients with an average blood loss of 1.5 liters. Most fusions were posterior. There was one in the combined group and one anterior fusion. The most common operative time was between 2 to 6 hours, with about a quarter being longer than that. The intraoperative head position, the most common head holder used or commercial head holder used was about 28.6%, with a pillow used in a third of patients. Head position was flat in most of these patients at 57%, with those that developed this complication. There was evidence of eye or orbital swelling in 28.6% and evidence of eye pressure in one patient. So in terms of the division between the types of visual loss, so again, ischemic optic neuropathy was most common at 38%, with an even distribution between anterior and posterior. Central retinal artery occlusion occurred in about a quarter of patients, as well as cortical blindness. Most patients had unilateral partial complications at 38% and bilateral total in about a quarter of patients. The timing of the visual loss was commonly within the first postoperative day at about 60% of patients developed within that first postoperative day. About 50% of patients recovered complete visual acuity, and there was improvement in 20% of these patients. So in terms of previous reports, the NAS database has reported a decreasing rate over the last decade from about 0.09% to 0.03. We saw a similar threefold decrease over the time period that we looked at. Again, risk factors for POVL include anemia, hypotension, prolonged procedure time, and prone positioning. And the proposed mechanism is a combination of decreased oxygen delivery and impaired flow, which typically leads to ischemia or infarction of the retina, optic nerve, or the cortical areas. Hypertension in previous studies was found to be the most common preoperative risk factor. We similarly found that at 23.8% in our study, but the true role as a causative factor is still unclear. Previous studies have shown the rates of partial or complete recovery to be between 36 to 57%. Again, our analysis showed complete resolution 48% and improvement in 19%. Limitations of our study. It's a database study. We did not have control groups to better assess the risk factors for POVL. Again, it's a large patient database with voluntary submission of data with unclear accuracy or completeness. The lack of information on postoperative evaluation and workup of the POVL complications is another limitation. So once again, our conclusions is that the incidence of this complication is about 12.5 per 100,000 deformity cases, with an average rate of 0.01%. The rate is much higher in patients with a diagnosis of kyphosis. 60% of these complications occur within the postoperative day, with resolution in nearly 50% and improvement in about 20%. Thank you.